Dr. Cesar Rodriguez is joining us today to talk about Talquetamab side effect management. We chose today's topic because knowledge is power. We're so lucky to live in a time with so many treatment options for multiple myeloma, but often the side effects can be tricky to navigate. We're hoping that today's talk will help those who are currently being treated with Talquetamab and those who are considering it will feel empowered to meet those challenges head on. With that, I'm going to go ahead and do a quick introduction of Dr. Rodriguez, and then I'll turn the time over to him. So Dr. Rodriguez is an associate professor of medicine at the Icahn School of Medicine at Mount Sinai, the Tisch Cancer Institute and Center of Excellence for Multiple Myeloma, and serves as clinical director of multiple myeloma at Mount Sinai Hospital. Dr. Rodriguez has extensive experience treating patients with plasma cell disorders. He's a member of the International Myeloma Working Group, which conducts collaborative research and produces consensus guidelines for the myeloma community. Dr. Rodriguez has more than 10 years of experience in clinical research and is the principal investigator of numerous clinical trials for multiple myeloma, focused on early drug development and immunotherapies that include T-cell and NK cell-directed therapies. He's also working on a 3D organoid model to better understand the biology of the tumor niche. And this is just a personal aside, but as someone who desperately wants to learn just a second language, I was blown away when I learned that Dr. Rodriguez speaks 4 languages. He's fluent in English, Spanish, French, and the language that I most recently tried to learn, which is Italian. So it is my pleasure to turn the time over to Dr. Rodriguez.
Thank you so much, Cindy. Let me share my screen so I can. Okay. And are you guys able to see my presentation?
Yes, it looks good.
Perfect. Okay. So what I would like to do today, we have how much time again? Is it an hour?
An hour, yeah.
Okay, perfect. So I don't have too many slides because I want to make this. I want to talk a lot about my experience, but I would like to talk about how we manage Talquetamab toxicities, because it is one of the, like Cindy said, one of the new therapies that we have now available to treat multiple myeloma that has really changed our expectations of therapy, especially in people who have had multiple lines of therapy. And I want to first talk a little bit about what it is, the molecule itself, and then a little bit of background to understand the side effects that we're going to see with this agent. And at the end, I'm gonna have plenty of time to answer questions and try to, anything that might be more from your own experience or other questions that I might not have brought up. But Talquetamab is a bispecific antibody, and a bispecific antibody is what it basically means is our body has antibodies, and we use antibodies as part of our immune system to be able to detect bacteria, viruses, and when that happens, the antibodies signal the rest of the immune system to come and fight that infection. Normally, the way these antibodies work is that it binds to a protein on the surface of something, and once it binds to it, it triggers a signal to come and alert things, the immune system to come in and attack or try to destroy the virus, the bacteria, or whatever foreign body it is. Now, if we go back a little bit before we start talking about bispecifics, and we think of monoclonal antibodies like daratumumab, elotuzumab, isatuximab, these monoclonal antibodies that have been approved since 2015, they're very similar to a normally functioning antibody from our body, that it binds to the surface of a protein surface, and then it starts to send the signal to try to attract the immune system. Bispecifics go a step further, and they not just only bind to the surface protein of the myeloma cell, but it also has the ability to bind to the surface of a protein in the immune cell. And this particular immune cell for Talquetamab is a T cell called CD3. So now it has bound from one side the myeloma cell, and from the other side the T cell. And once it has both bound, it activates the T cell to destroy the myeloma cell. So it's almost like a seeing eye dog that actually drags the immune system and the immune cells to where they need to be and guides them to where they need to be attacking. So on the surface of the immune cell or the T cell, it binds to what's called CD3, which is a protein that's on the surface of the T cell. And then on the surface of a myeloma cell, it binds to a protein called GPRC5D, as you can see here. So here in this graph on the left, you see the myeloma cell, and then this green portion is part of the bispecific antibody that is binding to the GPRC5D, which is the protein that's on the surface of the myeloma cell. And then the other half of the antibody, which is the orange part, binds to the protein that's on the surface of the T cell or the immune cell called CD3. And then once it's activated to both, it's going to release some enzymes that are in the T cell, in the immune cell, to go and destroy the myeloma cell. But not just that, it also releases these cytokines that we call to help attract more of the immune cells to come and destroy the myeloma cell. Okay, so that's what a bispecific antibody is. And in Talquetamab, it's targeting the GPRC5D on one side and CD3 on the other side. Now, Talquetamab is a drug that was approved after the Monumental 1 study showed its results. And this study had 2 different dosing schemas and 2 different concentrations of the drug or dose of the drug. One schema used step-up dosing to try to water down the side effects and reactions of the immune system when you first give this drug, and then give weekly doses therefore going forward. While the other regimen used the same step-up doses, added 1 additional step-up dose, and then instead of doing weekly dosing, it gave the treatment every 2 weeks until progression. So let's talk about the step-up dosing, because this is also something key to try to help tackle the side effects. With immunotherapy, since we're activating the immune system, we are actually I want you guys to think that we're almost, I don't want to say that we're causing the flu, but it's going to activate the immune system and it's going to give symptoms similar to when somebody has an infection, similar to a flu or a bad cold. What's going to happen when your immune system gets activated? There's inflammation, there's fever that can happen, and there's a lot of movement of fluids and cells within the body to try to get to where the infection is, which can lead to a decrease in the blood pressure if the infection is too severe, or a drop in the oxygen level if there's fluid that kind of tends to go to the lungs, especially if somebody has a pneumonia. That's like the normal immune response of an infection, especially a severe infection. With the bispecifics, since we're activating the immune system and we're activating it a lot, it's going to do a very similar effect. About 70% of the patients are going to develop a degree of fever. And then that fever, depending on the severity of the fever and how long that fever lasts, it can be accompanied by either a drop in the blood pressure or a drop in the oxygen level. And for that, we give medications to help stop the inflammation and help stop the fever. The most common medication that we give is tocilizumab when somebody starts having these symptoms that we call cytokine release syndrome or CRS. But another way of trying to help make these side effects more manageable is instead of giving the first full dose, the first dose is divided and it's spaced out, and you get a baby dose so that your body gets just a little taste of the drug. And then a few days later, you get a larger dose so that your body starts to get a bit more familiar with it. And then you get the third dose, which is the full dose, if you're doing the weekly dosing. If you're doing the every 2-week dosing, there's going to be a total of 4 step-up doses. Okay, so that's a way of trying to prevent the CRS. And then the tocilizumab and dexamethasone are 2 drugs that we use very often when somebody does have CRS. Now, another potential side effect that we see during these step-up doses is neurologic changes or toxicities. Sometimes it's associated with the CRS and the fever, and sometimes it could be independent from it and happen on its own time. The majority of the times it tends to happen a little bit after CRS if it's going to happen, but I don't want you to think that that's going to be the rule. Especially in myeloma, there's a lot of exceptions. But we have now the CRS and we have possible neurotoxicity. And now for the neurotoxicity, if somebody is having these symptoms like confusion or difficulty speaking or difficulty writing or having shakes, or even difficulty moving, which is rare, but it can happen, we treat it with either dexamethasone or another medicine called anakinra. So we've now identified medications that help reduce the severity of CRS and to try to cut it quickly. And we've also identified therapies that we can use for somebody who's developing neurotoxicity or neurological changes. These two side effects, CRS and neurotoxicity, tend to happen only during the step-up dosing phase. It is extremely rare that we're going to see these side effects once somebody's already on the full dose and is already out in the clinic and getting their maintenance doses or subsequent months of therapy. But the step-up doses, they tend to be given in the hospital so that if one of these side effects happens, we can give those medications quickly and the nursing team is there. And if it's a severe thing, then we have the ICU and everything else. But now we're getting a little bit bolder since we know how to manage these symptoms better and try to prevent these symptoms from getting bad. We are at some of the institutions, we are doing this all outpatient, where the patient comes to the clinic, gets the treatment, then goes home or goes to a hotel nearby, and then comes 2 days later and gets the next dose, and then comes 2 days later and gets the full step-up dose, or gets another step-up before the subsequent step-up dose. And they might be given dexamethasone so they can have at home in case they start to have some symptoms. They call the doctor or whoever's on call, and then they would receive instructions as to whether they should take medication and if they should come to the clinic or if they should come to the emergency room or what to do. But there are very few cases of patients who do develop CRS or neurological toxicities after they've been outside of the hospital and getting the treatment for months or months into therapy. And these tend to be caused, if it were to happen, the majority of the time is because the patient is having an infection. And if somebody's already having an infection, the patient already has inflammation in the body because the immune system is already activated. And imagine giving a dose that's going to activate the immune system even more. So it's just going to give more fever. So whenever somebody has an active infection, we hold the treatment and we do not give the Talquetamab. Okay, and then we resume this treatment once the infection is completely cleared. That way we can reduce the side effect of cytokine release syndrome or neurological toxicities. But Talquetamab, as opposed to other bispecific T-cell engagers, is the only one that's currently commercially available that targets GPRC5D, which is the protein that's on the surface of the myeloma cell. All of the CAR-Ts that are available right now, and all of the other bispecifics that are available right now commercially, they target BCMA. So why am I making an emphasis on GPRC5D? Because GPRC5D is a protein that's expressed mainly in myeloma cells, but there are a few other areas where these cells, where this protein is expressed in our body. And these tend to be highly keratinized or with a lot of keratin. Cells that have a lot of keratin are highly keratinized cells. What are they? Nails, hair follicles or hair, but it's gonna be expressed not when the hair is growing actively. It actually is expressed when the hair is not growing actively. So it doesn't cause side effects with hair in terms of losing your hair or changing the color or anything like that. But in the nails, it can cause some changes. It's also seen in some glands in our skin, sweat glands or sebum glands. And the glands that are going to be expressing GPRC5D is the ones that don't have hair. So if we think of our body, places of our body that we said sweat, but we don't have body hair, it's the palms of our hands and the soles of our feet. So we might see some side effects there. And I'm going to talk about that in a little bit more, right? All of these side effects. And then the other area where we tend to see this GPRC5D expressed is in some tongue cells, not the taste cells, but what's called the filiform papilla of the tongue. These are cells that are around the taste glands or the taste bulbs or the taste cells. So even though it's not the taste cell, the one's in charge of taste, it could potentially interfere because it's in the vicinity and it can cause some problems with it. So what I want to focus on now is I want to talk about all of these potential side effects because the GPRC5D is expressed in these cells that are not myeloma cells, okay? So just to give you guys an idea, I know this is a lot of looks very scientific, but I want to focus on these red and yellow rectangles. The infection rate of somebody who's getting treated with Talquetamab is about 58% of the patients will have some type of infection during the course of their therapy. And this infection could be a very mild infection, or it could be a severe infection that would require hospitalization. If it's a severe infection, the majority, it's going to be about 15 to 20% of the cases where people might require hospitalization. And the majority of the times, it tends to be respiratory infections. So this is not, the infection rate here is not as high as BCMA-directed bispecific therapy like Talquetamab and Refractory. But we are seeing, like I said, 3 side effects that we are not usually seeing with the other bispecifics, and a few side effects that we don't see with other myeloma therapy. One is the rash, which can develop in the whole body, and that's something that can happen with any drug. So I think we've all seen somebody develop rash to a drug for myeloma, where the physicians that are treating you, the doctors that are treating you, are very familiar with drug rashes. But we also see the nail changes because this GPRC5D is expressed in the keratinized cells, so that the nails are very highly keratinized. And I'm going to show you some pictures of that. And here it says there's no grade for that, but we'll talk about how often this happens. And then the other thing is the dysgeusia, which means a change in taste or loss of taste. And this is a very unique side effect that's happening with Talquetamab that really doesn't happen with the majority of the other myeloma therapies. We might experience it when we're doing a transplant, or we might experience it if we're having too much chemotherapy that's very potent. But there isn't really a drug that you would say this drug in particular is gonna cause loss of your taste, or it's gonna alter your taste significantly. And this Talquetamab does. Now, let's go into detail of each one of these. So let's start with the skin. And sorry if this is too graphic, but I want you guys to have a visual of what I'm talking about when we talk about skin toxicity. Right here on the far left, you see the belly and the chest of a man who received an injection of Talquetamab. And you actually see here the area that's peeling, that's where he got the shot. But he developed a rash throughout the whole trunk, the front and back, and the inner thighs of his body. And this type of rash is a typical drug rash that you can treat with either Benadryl or a small dose of steroid. It might cause a little bit of itching, it might cause a little bit of discomfort, but it is not something that's going to be severe or very life-threatening. And the symptoms tend to go away quickly. If you have a rash like this, it doesn't mean that you cannot have that therapy again anymore. You could continue the therapy and the rash disappear. It's just the initial reaction of the body to that drug. But like I said, GPRC5D is expressed in the palms and in the soles of humans. So normally about between 60 and 70% of the patients who get Talquetamab are going to develop peeling or desquamation of their hands and their feet at some point. And this peeling or desquamation tends to start towards the end of the first month or during the second month. It doesn't happen immediately as you start treatment, and it doesn't usually happen months into therapy. It's the end of the first month or the second month that you tend to see this. And what people describe when this happens, especially with the hands, is that they start to feel some tenderness in the palm, almost as if they burn themselves very slightly on the stove. And when somebody describes those symptoms, we tend to give them some therapy to try to help with the inflammation. And then we give them creams to help, one, remove the dead skin or remove all of the peeling skin, but at the same time protect the skin so that new healthy skin comes out. And that can happen in the feet and it can happen in the hands. So for the dry skin, obviously we want to recommend a lot of hydration. For the scaling of the hands, we could give some steroid cream, very low intensity of the steroid cream, if somebody's having the tingling or the tenderness. But once the tenderness is gone or the tingling is gone, we stop the steroid cream. The peeling is just going to continue to evolve. It's like if you had a sunburn and you're no longer exposed to the sun, but you're going to peel towards the end of that week anyway. So the same thing happens with the palms and the feet. You had the insult, and even though the insult is gone or taken care of, the peeling process is going to take its own course. We encourage everybody to hydrate, use a lot of hand lotion for the hands, keep the hands moisturized. And we also encourage patients to be careful with hands, not to be washing their hands with a lot of soap and hot water, to avoid very cold temperatures, to wear gloves if possible. And if you're gonna be, let's say, washing dishes, it wouldn't be a bad idea to use gloves. Or if you're gonna be having your hands under, like submerged in water, try to avoid that because you don't want to have the anything that's gonna predispose the skin to start peeling. And then for the rash, one of the things that we recommend is if they're having itching, something for itching, Benadryl or Zyrtec or Allegra or any of those antihistamines. And if it's a localized area that is pretty severe, we can give a topical steroid in that area. If it is a significant rash throughout the whole body, we might just give a systemic steroid or an oral steroid so that can take care of the body rash. Now, talking about the nails. These are very typical pictures of what happens to the nails when somebody starts Talquetamab. And the nail changes don't happen with the step-up doses either. They tend to happen during this end, towards the very end of the first cycle or somewhere during the second cycle. And as long as somebody is receiving treatment, those nails are going to continue to grow like this, almost like if you have a fungus infection or something's wrong with your nails. They're going to chip. There is the risk of these nails falling off and then new ones growing, and then those falling off and then new ones growing. As you can see here in the middle, you have somebody who has the healthy nail from before they started Talquetamab, and then they have the new nail, which is growing on almost like if it's very damaged nail. And then there's some areas here that are showing signs of new nail. Okay, and that new nail is going to chip off as well and be flaky and fall off. So what can we do for the nails? One, we're gonna try to avoid frequent long durations of water immersion. Use gloves. If your nails are peeling already or they've fallen off or they're like clinging to clothes, because that's one thing that could potentially happen, that they can cling to clothes, or when you're washing your hair, they can cling to your hair. You can use gloves, or you can use these little, I don't know what they're called, but within each one of your fingers. You're gonna use a lot of moisturizer and an emollient. So Aquaphor is the best. Vaseline could be an option, or you can use a very nourishing hand lotion. Just make sure that it doesn't have scent. That's the key thing. And it can have oatmeal or not. That can help us well with soothing the hand and the symptoms and hydrating it. But the reality is that any cream that does not have any scent could potentially help. You can file the edges of the nail, because as you can see in the previous picture, the nails are very disrupted. So you can file it so that they don't cling to the clothes and snag. You can also use hardening nail polish or regular nail polish to give a layer above it, so that if there is any rough edges, that it gives it this like smooth surface. But at the same time, if you're doing this small polish or nail hardener, is that you're protecting the nail from it snagging in your clothes or whatever it is that they could potentially snag in. Vitamin E is something that has been discussed as something that you could potentially do and place it in the cuticle. I don't know how much it works, but if you have the money and it's not too expensive, it's worth a try. You want to avoid tight shoes, because if you're having tight shoes, that's going to be pushing against the toes, and that's going to disrupt the nail formation. So that, in addition to the talquetamab, you have bigger problems. You want to avoid tight shoes. You want to wear soft socks for the same reason. You don't want the foot to be against pressure on a shoe or a boot or a very rough situation. And you could potentially use steroid cream, like I said. If you're having the rash is too bad, you can ask for a topical steroid cream and they can give it to you, and you can just use it in your hands, palms, hands, or anywhere that you have that's in the hand area. Keep your nails short, keep them clean. And if you're having nails that are peeling off, apply triamcinolone cream where the nail is falling off. So that can help regenerate cells, but at the same time, it can help protect the body from rejecting bispecifics in the near future. And then finally, like I said, wear gloves or when you're outside in the cold or when washing dishes. Now for the oral toxicity, you have altered taste, you can have dry mouth, you can have problems swallowing, which can lead to weight loss. And some of the rationale for this is the following slide. So dry mouth or change in taste is very subjective. And it's hard to pinpoint exactly where the symptoms are and what type of symptoms it is. So we did a study with approximately 24 patients that had some degree of dysgeusia or change in taste or dry mouth, and try to understand it a little bit better. But we had this one patient who got an MRI before starting the treatment, was started on treatment, and within a week or so, about a couple of weeks after treatment, got another PET scan because the patient was complaining of significant pain, and they were concerned that she was progressing somewhere else. But that didn't show that the disease had progressed. There was what we call an uptake in the saliva glands. So here is the PET scan before starting treatment. You see a little bit of pink here, but it's not too bright. Pink is going to show us, or whenever a PET scan lights up, it tells us that there's either inflammation or tumor cells in that area. So it's hard to sometimes distinguish which one it is unless you have a clinical picture. But here, this one was pretty normal and benign. And then it was repeated after having started talquetamab, and we noticed a significant increase in the uptake of the PET scan. So here we see how this is much brighter than the one here on the top, okay? Now, how can we manage these change in taste or dry mouth? Because some patients complain of dry mouth and change in their taste. Others complain that they have a sensitive tongue and a change in the taste, and others complain that they're having difficulty swallowing. And that can happen for several reasons. So here I showed how the saliva glands are intensified or are taking more inflammation once we started the treatment. And this could be because there might be some plasma cells in the saliva glands that are being activated or triggered with the talquetamab and bringing inflammatory cells into that area, and that can disrupt the production of saliva. So if that's the case, patients are going to tend to have more symptoms of, I have dry mouth, I chew, and as I chew, I feel like it's turning into this ball of cardboard that's getting larger and bigger and harder to swallow. or I feel like it's hard to chew and swallow. It gets stuck in the back of my throat and I have to spit it because I can't swallow it. That's a common side effect of somebody who's producing less saliva. Another side effect is if the talquetamab is irritating or causing inflammation in the cells that are on the tongue around the taste buds, it's going to cause inflammation of the whole tongue, which can cause inflammation of the taste buds. And that's what we call glossitis. So an inflammation, almost as if you got your tongue scalded by hot water or some hot food. And then you're going to have a harder time being able to distinguish the flavors. But it doesn't necessarily going to make your mouth dry. So those are different scenarios of this oral toxicities that we have with talquetamab and where it could potentially be coming from. So for taste changes, we really don't know exactly the mechanism of how it's happening 100% or how it can prevent it. So we've been experimenting with different home remedies or experimenting with experiences that we've had from other diseases or therapies. And before focusing on myeloma, I was a transplanter and I did allogeneic transplants. And these patients tended to develop what we call graft versus host disease of the mouth. And that can lead to dry mouth, can lead to changes in taste, and it can lead to mouth ulcers. And the way we treat it for these type of patients that get a transplant from a donor, not their own transplant, and are rejecting it, is we give them a steroid mouth rinse so that their inflammation improves in the mouth. And that helps with their symptoms. So I said, well, why don't we try it with with talquetamab because it's having a similar side effect. So we're doing these mouth rinses. We started doing these mouth rinses once people had the symptoms and we realized that it wasn't helping. Now we're using it as a preventative. And we start these mouth rinses with the first step up. Why? Because we're seeing patients are losing their taste as early as their second step up dose. They haven't even left the hospital and completed the step up doses and they're already having changes in their taste. So we're giving it with the first step up, and they're going to be taking it, doing mouth rinses where they swish and they spit it. They can't swallow because you don't want to be swallowing too much steroid. So you want to just spit it. And we do it 3 times a day, and we are seeing patients. Some of them are still having changes in the taste, but it's not as severe. And some of them might have the taste changes, but it's a little bit more delayed. And I have the theory that some of these who are having the delayed taste is change in taste is because they forget or they get tired of it or lazy and they start to forget and don't do it 3 times a day. And then at that point, the inflammation starts to happen, whether it be in the saliva glands or the tongue. And then that triggers the change in the taste. So that's one thing that we're doing. We're learning about it. We're trying to see if this really works. There's a study called the Talisman study that is looking at this option and some other alternatives that to see which one is the best and try to learn from it. But that's to prevent it. Now, if you already have taste problems, what can you do for that? One thing that you could do is, depending on what your taste is lacking or what your flavor you're lacking is how you can compensate. So you can use cinnamon to help with flavor. You can add spice or salsa, whether it be herbs or actually spicy things, hot things, depending on whether you have a sensitive tongue or not, is whether it's going to help or not. And then some people actually have used MSG, which is monosodium glutamate, which is seen often, it's used often in Chinese food to enhance the flavor. And some people claim that by adding MSG to the food, it does increase their taste and the flavor. So it's just a matter of trial and error and experimenting with different substances to see what works and what doesn't. Now, if you're complaining of dry mouth is a little bit different because dry mouth is more a reduced production of saliva. And for that, we want to try to keep the saliva glands cold. So one thing that we've been doing in some of our patients is that we're giving them ice packs for them to wear on their cheeks as soon as they start therapy, or encourage them to eat frozen fruit pops. So we have them buy popsicle makers and then put water there with some flavoring, preferably sugar-free, or with lemon or lime or orange so that it can have some citric and acidity. and then suck on that. And that's gonna help one, cool the mouth so that there is less blood flow to the mouth and therefore less inflammation to the mouth. But at the same time, it's going to help if you add citrusy flavors to it, it's going to help with stimulating saliva production. When you're eating, if you eat dry food and you have a dry mouth, it's going to be harder to chew because the saliva needs to mix with the food in order for it to be broken down and swallowed. So if you're having problems like that, or you're having problems with taste, dry mouth, or swallowing problems, then I will encourage you to take small bites, and before you even start to chew, take a small sip of a liquid, and then chew with the liquid at the same time. And that can kind of substitute the function of the saliva and can help to some degree. Having small bites also helps with the ability to swallow. If you're having problems swallowing, you need to make sure you take smaller bites and have some liquids while you're chewing to help with it. It's very rare that patients cannot swallow completely, but we are seeing that some patients are having some problems that are affecting their weight. And if that is the case, we tend to hold the treatment, but we also refer the patient to a nutritionist or a dietitian to help figure out how we can help prevent the weight loss. Now this slide here shows how we've done some experiments or some testing, I should say, where talquetamab can be given on a weekly basis or it can be given on every other week basis. And we believe that these side effects are related to the continuous exposure of these agents in our body. So we did some studies, and in people who were having side effects, whether it be skin or nails or taste changes or weight loss, we spaced out the frequency of the treatment. So if they were getting it weekly, we spaced it out to every other week. If they were getting it every other week, then we spaced it out to monthly. And we did see that there was a trend to improvement in the skin peeling and the mouth side effects, the dryness or the taste. But one thing that, and some discrete improvement in the nails, I don't want to say that that's really the case, but it's some improvement in the nails. But the one thing that we really haven't changed much with these interventions is decreasing the risk of weight loss if your mouth and your taste and your ability to eat is that severe. Now, very few patients actually have to discontinue treatment because of these side effects. And if they do have to discontinue, it's going to be because of the taste and their inability to eat. We haven't had anybody discontinue it because they're having problems with their nails or because of the desquamation of the hands and the palms. So that's a good thing to keep in mind. And in terms of the people who are on therapy, when we space it out to monthly, or sometimes we're even spacing it out to every other month, we are seeing that their taste gradually improves. It doesn't normalize completely in a good number of the patients until they're completely stopped from therapy. But because this is a therapy that people respond to very quickly, and we see responses within a month of therapy, then we can quickly space out the frequency without actually impacting the efficacy of these drugs. And that's something that we're exploring with more. We're trying to explore of spacing out the drug and doing the therapy for a finite period of time so that then patients can recover from the taste and be able to enjoy the things that they like. Why? Because approximately 95% of the patients are going to have a change in their taste, whether it be mild or severe, but the majority of the patients are going to have a change in the taste. So we make an effort in trying to tell patients that their taste might change. We don't know how severe, but it is something that's a side effect. But on the positive side, the response rates are very good. So that's about 72%. So some patients say, oh, I lost my taste, but it was worth it because I'm in remission. Or some people have been on this therapy for a long time, a year or more, and like, I don't know if I already got used to it, or I'm mentally like thinking to myself, but I feel like the taste is gradually getting back. It's not normal, but I can taste some things. And we don't know. So right now, the Talisman and some other studies that we have are helping to try to determine what are the things that are triggering these side effects and what are the effective therapies that are actually going to, one, prevent them, or control them if the symptoms do occur. And I think that's my last slide. There's a few more things I do want to bring up, and that is, I talked about how with taste, this is caused because you're having a decreased production of saliva, because there's GPRC5D expressed in some plasma cells that are there in the glands or in the mucosal lining. Well, that can happen as well in the lungs. And one of the things that I have noticed is that when somebody who is on Talquetamab develops a sinus infection or they develop a pneumonia, that secretion, that thick secretion or the phlegm tends to linger longer. Why? Because the phlegm is thicker and it's harder to cough up. So in those cases, what I've been telling patients to do is give them Mucinex, the one that helps dissolve mucus, and that helps them a lot to clear their symptoms. It's not gonna shorten their pneumonia or their sinusitis. You need the regular therapy for that. But the Mucinex is a good addition to have so that it doesn't stay with a congestion for a longer period of time. The other side effects that we're seeing that I didn't bring up today is, in the slides, is viral reactivation. So there's some degree of immune suppression with this drug. And people who have had hepatitis in the past, or people who have had shingles or varicella, chickenpox in the past, these can reactivate at some point during the treatment. So while you're on treatment, we give an antiviral therapy, acyclovir, which can actually help reduce the risk of shingles. If somebody had hepatitis, we give a prophylaxis medication to try to prevent hepatitis reactivation. And then periodically, every about 3 months, we might be doing screening to make sure that there isn't any reactivation of these hepatitis. CMV is another virus that can potentially reactivate. It's rare, but it could potentially happen. And doctors tend to look for this if somebody's having an unexplained fever or weird vague GI symptoms, diarrhea, or like queasiness and things that are just not explained with the workup that they've done, or respiratory symptoms that are not explained, some viral respiratory infection or common cold or things like that. So those are things that we also monitor periodically, and we encourage patients to get the RSV vaccine, to get the flu vaccine, to get the COVID vaccine. Any vaccine that's going to help reduce the risk of respiratory infections, definitely encourage it. Now, while BCMA is known to have more infections than Talquetamab, so Teclistamab, Elranatamab, CAR-Ts tend to have more infections, Talquetamab still has a degree of infections. So we sometimes replace the immunoglobulins with IVIG from other people, healthy people, to help boost the immune system. And somebody who has low IgG levels in their body, we're going to be giving them IVIG on a monthly basis to try to help them fight any potential infections that their body might have. And with that, I conclude, and I want to open it up for questions.
Perfect. Thank you so much. That was a lot to get in the time that we've had, so thank you. We do have a pretty active chat, so I'll just start at the top and we'll get through as many as we can in the time remaining. We've got 2 questions from Helen. The first is, have you seen alopecia as a side effect? After 11 months on Talquetamab, I'm experiencing hair loss. Is that something you've seen?
So yes, we have seen it, and we have seen reactivation of autoimmune disorders. So because we're playing with the immune system and we're activating the immune system and heightening inflammation, somebody who might have had vitiligo can have an exacerbation of vitiligo. Somebody who might have lupus might have an exacerbation of lupus, or Crohn's, or irritable bowel syndrome, or alopecia, because these are immune mediated. There are people who might not have any of these symptoms prior to starting this treatment, but might have the predisposition, and a small percentage of these patients might develop these symptoms during the treatment. And what we do is, for example, for alopecia, we hold the treatment for a while and we give topical steroid, and that helps the hair grow back. And then we re-challenge them with Talquetamab, and a lot of people don't have any issues, but if it continues to happen, it's just using topical steroids or spacing out the frequency of it.
Perfect. And next question she had is, do you have experience with long-term Talquetamab patients? She's wondering if there's any information on maintenance going forward. Right now, she's down from 1 shot a month instead of 2. Just wondering what long-term looks like for these patients.
So we do have patients on Talquetamab that have been on treatment for, I think, 4 years now, because we had it around the pandemic, when the pandemic started. And a lot of those patients that are still getting treatment and are still in remission, we have transitioned to monthly dosing, and a few of them transitioned to every other month. Now that we have commercially available Talquetamab, where we like to play and do our own thing. In myeloma, we don't like rules. And one of the things that we've been doing is we're not following the schema of doing weekly therapy indefinitely or every other week dosing indefinitely. If you're doing the every other week dosing, a lot of us are switching from every 2 weeks to monthly between 2 and 4 cycles. So 2 to 4 months from therapy if they've achieved their desired response. And like I said, the majority of the patients are going to have response within the first month, and the peak response is going to be approximate, that it's going to be achieved within 3 to 4 months. So it's easy to transition to spacing it out. And we are doing bone marrow biopsies once a year and checking for minimal residual disease. And if somebody has no evidence of minimal residual disease for 3 years, we're planning on stopping it at that
Nice. Very good. Next question is, with the severity of the side effects decreasing over time, does that mean that the multiple myeloma cells have likely found a way to deal with the toxicity, or is this unrelated?
This is unrelated. So yeah, I would say that's unrelated.
Okay, perfect. And this one you answered as well about any thoughts on getting pneumonia and RSV vaccines prior to treatment to decrease respiratory infection risk.
So we do encourage you to get the vaccines. I wouldn't delay therapy so that you can get the vaccines. If you have the ability to get it quickly, get it quickly. I wouldn't get both vaccines at the same time. I would get one and then another one a week later. But I would definitely not hold the treatment just to get the vaccines. You can get the vaccines while you're on treatment. We just recommend that you get the vaccine, not the day of the injection, but somewhere between doses, so that you have the highest probability of mounting a response to that vaccine. Otherwise, it's unlikely that you're actually going to respond.
Perfect. Next question is, you see Talquetamab is effective in stage 3 aggressive patients as it is in lesser staged patients?
I'm sorry, can you repeat that?
Yeah. So the question is just if you're seeing it be as effective in more aggressive forms of myeloma, stage 3 aggressive patients, or as in lesser staged. So is it, yeah.
So this is not a side effect question, but it is a question. We are seeing patients who are on bispecific, whether it be Talquetamab, Talquetamab, Refractory, any of those, to have a poorer response or suboptimal response in several scenarios. One is if you have a lot of bulky disease. 2, if you have high-risk cytogenetics. 3, if you have plasmacytomas that are outside of the bones, what we call extramedullary disease. These 3 patients tend to have shorter responses or not as steep of a response, and they tend to relapse faster.
Makes sense. Okay. Next question is going back to the nail problem. It says, have there been any studies done to compare using vital protein collagen powder versus not? This patient said Pomalyst has messed up their nails and that the product is helping them be healthy.
So there are no studies at the moment for that. So we're just kind of going by urban legend or grandmother recipes or things like that. But I think that there's no harm in trying.
Perfect. And this is a similar as that one, just using gel nails on top of the nails. Any issues with that, or is that similar
So
to
I
just a, yeah,
so I have a problem with gel nails because with gel nails, if I'm not mistaken, you need to use UV light to harden
yeah,
the gel, and that can predispose to skin cancer. So
okay,
any myeloma patient should not be using gel nails, especially if you're on lenalidomide or pomalidomide or thalidomide or any. I would say just don't. I think there's an alternative to gel. I don't know what it is. That doesn't require UV exposure. I don't encourage you to use the ones that also require chemicals because that's going to really dry up your fingers and can predispose to more problems. So the best thing for Talquetamab patients is to just use thickening enamel, and just keep your hands nice and clean.
perfect. Might be our last question is, we talked about avoiding issues with reduction of taste. And I think you touched on this, is that will it be possible to recapture complete taste at some point? Or is the jury still out on that?
So I do have patients that have recovered their taste, not completely if they're still in therapy, but those who have stopped therapy, and they do recover the taste. It just takes a very long time. It can take up to 6 months to recover the taste because it's a slow process. For those who do stay on therapy and get spaced out to monthly or every other month, very interestingly, they say that their taste gradually gets better, and then when they get their next dose, they get a setback that lasts for a few days, and then it gradually continues to get better, and then the setback. So that's something that we've seen as well. That kind of, I don't want to say it proves because it's not scientific, but it makes us suspect that it is dependent on how frequently we're dosing it, and we're trying to work on that.
Okay, perfect. Well, I think that will be all the questions we'll be able to get to today, but I just wanted to thank you, Dr. Rodriguez. I know hearing from doctors about what they've seen through multiple patients and getting that information to patients that are considering these different therapies is really important. So thank you for sharing your time with us today.
No problem. Thanks for having me.
Okay, thank you. Go ahead and share, and we'll close out the end of the presentation. So if you have any further questions about bispecific antibodies, I wanted to highlight a new resource that was recently developed by HealthTree and reviewed by myeloma specialists. This guide simplifies the science behind bispecific antibodies. It provides a clear overview of how bispecific T-cell engagers work, their potential benefits, and the latest advances in research, with practical details on administration, side effects, and comparisons to traditional treatments. This guide empowers myeloma patients and their care partners to make informed decisions about their treatment journey. As you leave the session today, we would appreciate you taking the 2 to 3 minutes to fill out the brief survey about your experience during today's event. Our next relapsed refractory session will be happening in October. Dr. Benjamin Diamond will be talking about how the IRMA study is helping to personalize multiple myeloma treatment. So look forward to details on that in the near future. It should be available soon to register for. Coming up in the next couple weeks, on September 24th at 2 p.m., our Black Myeloma Health group will be discussing thriving in the new normal, living your best life despite myeloma. Monday, September 30th, to round out our Blood Cancer Awareness Month, we will be hosting an Innovation for Blood Cancers webinar where we'll hear from 4 experts in different blood cancer fields, talk about past, present, and future of blood cancer care. And then October 1st, we'll hear about upcoming changes to Medicare for 2025. The link to sign up for any of those events and many more others is found at the bottom of this slide and will be sent out in the follow-up email within 48 hours of the event's completion. I'd like to again thank our sponsors, Adaptive, AbbVie, Genentech, Johnson & Johnson, Pfizer, Regeneron, and Sanofi. And lastly, I'd just like to take a quick second to talk about the Track My Disease feature in HealthTree Cure Hub. Once you've connected your medical records, the Track My Disease feature provides you with the ability to gain one-of-a-kind access to your health information, encompassing lab results, genetic profiles, and treatment history, offering you invaluable insights into your own medical journey. On the screen, I have the link to sign up for HealthTree Cure Hub, along with the email address to our amazing patient navigators who are available to help you create an account and connect your records. I'll also include this information in the follow-up email. And finally, I just want to say thank you again for helping us build a strong multiple myeloma community. I've added my email address to this slide, so please don't hesitate to reach out if you have any questions or if I can help in any way. I appreciate you all and hope you have a great rest of your day and hope to see you again soon.